I was asked to sort of kick this off by talking about the classification of acute kidney injury and a conceptual model. And the important thing about this is that it remains an evolving process that, as you'll see, is continuing to evolve as we understand more and more about this condition. We began many years ago with the Tower of Babel, where there were as many definitions of acute kidney injury as there were papers on acute renal failure, which is what we called it at the time. This led to enormous amounts of confusion in the literature and an inability to compare one study to another. This led to a coming together of multiple groups from around the world, intensivists, nephrologists, and others, to establish the first consensus definition of acute kidney injury known as the Reifel criteria. A few years later, we came out with version 1.2, which tried to close a gap in the original Reifel criteria, particularly as it relates to this problem, where you have patients that have underlying chronic kidney disease, perhaps, baseline creatinine that is elevated, and to expect them to get a 50% increase before you call it acute kidney injury is unreasonable, and therefore using something less than that to call it stage 1 or risk. Importantly, though, this can't be over a very prolonged period of time, because then that's, again, not acute kidney injury. Furthermore, it can't be compared to a historical value if you're going to use this 0.3 milligram per deciliter change. It has to be an observed change over a relatively short period of time. So these criteria provide complementary information and allow one, together with the urine output criteria, to classify most cases of acute kidney injury correctly. But you do run into situations where patients may present further in their course, and you may not have the information available to how they got there. And this will lead to diagnostic confusion. Imagine a patient coming in with an elevated creatinine, not knowing whether it's acute or chronic, the creatinine coming down, and an inability to determine what's actually happening with this patient. And this happens not infrequently. So these are a comparison of the AKI criteria using the 0.3 alone versus the original Reifel criteria with a 50% rise without the 0.3 change. And you can see that there are the lowest risk for patients who are classified as having no acute kidney injury by either criteria. If you have stage 1 criteria by the AKI modification, but not by Reifel, which means by definition this is a change of 0.3 milligrams per deciliter over less than 48 hours, you see that you have a very significant increase in mortality. It goes from 12 to 25%. But look here, you also have a number of patients who don't have the 0.3 change. These creatinines are perhaps falling after admission, and they present a large number of patients with a variety of different outcomes. So neither of these groups should be neglected from classifying as acute kidney injury. And indeed, together with urine output, you will find that nearly 2/3 of patients in the ICU have evidence of acute kidney injury. And when we saw that initially, we thought, well, gosh, that seems like a really high number, 2/3, even as high as 70%. And yet, if you ask the question, what proportion of your critically ill patients in the ICU have respiratory failure, defined by need for mechanical ventilation, for example, it's about 80%. What's the number of patients that have cardiovascular failure, defined by need for vasopressors? It's about 60% in most ICUs. So these numbers are very consistent with what we see in acute kidney injury. But we do have this situation where the baseline creatinine is often unknown. And particularly in larger countries, more mobile populations, such as the United States, where we often have patients that do not have a baseline creatinine in the system. And therefore, there's a need to estimate what their baseline creatinine would be. And we've suggested the use of the MDRD equation. I think some groups are validating the CKD-EPI equation for this application. And in this data set of over 10,000 patients from Pittsburgh, the Mayo Clinic, and Melbourne, Australia, we showed that indeed you could not really use a fixed creatinine for baseline creatinine in patients that are seen in the ICUs in these institutions, and estimating what their creatinine would be based on an MDRD equation was not unreasonable. In fact, the MDRD equation is a conservative estimate because you have a very low false positive rate. You do miss some patients. You tend to pick them up with the rest of the rifle criteria and with the particularly with the 50% change and the or the 0.3 rise, and you also pick them up with urine output. But it is a conservative estimate, not an overestimate. And there's been some confusion, I think, in the literature with regard to that, and certainly I think there's confusion in the minds of reviewers who argue that this estimate is somehow going to overestimate AKI. In fact, it's just the opposite. It tends to underestimate the rate of acute kidney injury, but as a conservative estimate, I think it's really quite reasonable. Another place for confusion in the literature is around the utility and the importance of urine output. This paper from my good friend Zoltan Endre from Australia showing that perhaps 6 hours of oliguria in an ICU patient at the 0.5 mLs per kilogram per minute is too liberal. But this is a small study, and when we analyzed a much larger data set of 32,000 patients, we found that urine output was informative at every level. This is a crosswalk of urine output only across the top and serum creatinine down the side, and combinations thereof. And you can see that if you go from no acute kidney injury by any criteria, have a mortality rate of about 4.3% with no risk of renal replacement therapy, all the way to 50% mortality with over 50% use of renal replacement therapy if both criteria reach stage 3. And you can see that going across this heat map, that urine output is informative at every stage, that a little bit of urine output on top of creatinine, just like a little bit of creatinine on top of urine output, becomes very informative. And so urine output is an extremely valuable biomarker for the staging of patients with acute kidney injury. And indeed, these data would suggest that there's even more complexity to staging acute kidney injury than just taking the worst criteria, because sometimes if the worst criteria is, for example, creatinine alone without urine output criteria, or urine output alone without creatinine criteria, it's very different than certain combinations. And these outcomes are seen over a 1-year period of time, where you can see again the same colors as on the prior slide relate to outcomes far out in the distant future, and also for risk of end-stage renal disease. What's missing, I think, in much of the debate and conversations around the conceptual model for acute kidney injury relate to its application, and one uses these definitions in different ways. If you're doing a quality assurance program and you're trying not to miss patients, then sensitivity is really what you care about the most. If you're trying to adjudicate outcomes of clinical trials, on the other hand, having specificity is what you're really interested in. Epidemiology is somewhere in between. But for clinical practice, this need changes over time. And over time, you get greater and greater diagnostic certainty as time progresses. And as you go from presentation to seeing what happens to urine output, to seeing responsive therapy, to clinical course, and hopefully not waiting for post-mortem information before you can make a final diagnosis. And you make a provisional diagnosis and you change it just like you do for any other disease process. But for clinical trials, we need to apply a more fixed criteria, which at the current time is a silver standard of changes in urine output and creatinine guided by the latest criteria, by the KDIGO criteria, along with some confirmatory evidence and lack of contradictory evidence. And this is played out in biomarker studies. This is where three adjudicators all agreed that there was acute kidney injury and the biomarker concentrations were highest. If it was 2 to 1, the next highest. If it was 2 to 1 against, or one saying it was and two saying that it wasn't, or all three saying no, had the lowest biomarker concentrations. And indeed, the patterns of biomarkers over time and their different characteristics and kinetics will perhaps change the way we ultimately define acute kidney injury. They cannot be used to define acute kidney injury now, in large part because damage markers may precede functional decline, as shown here, but they also can occur at the same time, where the damage is increasing as function is falling, or in some cases, function falls before damage increases. Therefore, damage markers provide no predictive ability to identify acute kidney injury. Meanwhile, this concept of stress, which is becoming more and more clear in the clinical as well as experimental evidence, is something that we will integrate into our conceptual model. And in the U.S., the FDA has approved last year a stress biomarker, which has also been available in the United States, in Europe for some time. These markers provide an early alarm, not damage, but an early stress marker for the kidney that can be used to identify patients at very high risk for going on to develop acute kidney injury. Later I'll talk about how they may also be used if one can induce them as a protective mechanism. So the modified, revised conceptual model, this has a reference of 2011, but I keep revising it as more information becomes available. This pathway, if you will, for patients moving from stage 1 to 2 to 3, developing complications, exhibiting damage markers, having evidence of functional decline, is also informed now by this concept of stress, and where stress fits into the overall conceptual model is shown there. And of course, we hope we can reverse this process in many patients, and indeed there's some evidence that that is exactly what happens in patients that have a good clinical outcome. And I think this information will be utilized in ways of reclassifying our diagnostic understanding, our diagnostic concepts for acute kidney injury, using functional criteria and damage criteria, and then integrating this stress concept on top of this for what will ultimately be the next version of rifle. To give you some clues as to the significance of that, this is some endotyping data, and the numbers are still very small and they don't reach statistical significance. But patients that are biomarker negative, in this case they have low levels of KIM1, urine NGAL, and urine collagen 4, these patients without these damage markers have considerably lower risk of death or need for dialysis at 1 year. The stress markers can also be used in this way. These are data recently published in JASN, in which an increase in the stress markers are associated with long-term outcomes in addition to the short-term outcomes that have been identified. And indeed, recovery is another part of our conceptual model and can be used as an outcome. We have a composite called MAKE, which is the composite of essentially death, need for dialysis, persistent decline in kidney function, and perhaps also including other things like renal hospitalization or progression of underlying kidney disease, or as Mig Chawla has suggested with Marseille, even including some cardiovascular endpoints as well. So our concept of acute kidney injury is, I think, a good start, but it needs further revision, especially for future research. That injury and impairment both lead to adverse outcomes. Markers of one will not replace the other. They'll be used in a complementary fashion to allow us to classify patients with acute kidney injury to diagnose them, but also to identify the severity of acute kidney injury and to track their outcomes over time. That stress also needs to be integrated into our conceptual model. We don't currently know, for example, that patients who develop acute kidney injury, if the stress markers decline, is that a way of monitoring our management, or is it simply a prelude to more severe injury that occurs in these patients? We are approaching the point where I think a new rifle will be emerging that's guided by biomarker data. It's unlikely, I think, to be a single biomarker for the reasons that I've described, but rather integrating multiple biomarkers in the same way that biomarkers are used for classifying patients with various other disease processes. We no longer talk about breast cancer, for example. We talk about BRCA2 positive or this marker negative breast cancer. We talk about differences in phenotypes that are guided by these biochemical signatures. And with that, I want to thank you for your attention.